I think we can start now because when we are on the time. Good evening and good morning, good afternoon, dear colleagues and friends. Welcome back from summer vacation. If you said that the summer only in July and August. So here in UAE, I think we are ready to start going back from the vacation, most of our colleagues here. So most welcome everyone. Good evening to my dear colleague and friends here, speaker and panelist. Good evening to all our attendees. They are following us in Zoom or Facebook or YouTube. And we hope to enjoy the day with an eminent speakers. John, can you share the screen just to introduce our speaker for today? So today we are going to have a speaker, a very eminent speakers. I have my dear friend, Dr. Ahmed Al-Khashab. He is an MD, ICO, FRCS, Head of Vitreoretinal Unit, Medical Director of Eye Consultant Center, Dubai Healthcare City UAE. He is a VR surgeon and he will be a co-moderator with me and moderating these sessions. My first speaker, it will be my dear friend, Dr. Madaf Rao, Consultant Ophthalmologist, Vitreoretinal Surgeon, Head of the Department of Ophthalmology, Borjil Hospital, Abu Dhabi, UAE. Next. Also, I'm today proud to have also dear friends, Dr. Iman Abdul Latif. She is an MD, lecturer of ophthalmology, uveitis consultant, Alexandria University, Egypt. And also, I am proud to introduce our dear friend. I call him the biggest boss for us, dear Dr. Danish Talwar. He is an MBBS MD, Senior Consultant Vitreoretinal Surgeon, Center for Sight, Safdar Jama in Cleve, I think, in Clive, and Indra Pratash Apollo Hospital, New Delhi. I hope that I pronounced clearly. I'm sorry for that. Also, we are having my dear friend, Dr. Patricio Lorenzo. He is an FRC SED, Edinburgh, FRC SI, FEBO. He's a consultant ophthalmologist. He is now working in Coreno Nasal. This is a center in Dubai, Cataract and LASIK Eye Surgery Hospital in Dubai. Also, my dear, what I can say, he is our boss, our friend, our teachers, Dr. Ayman Medanat, a senior consultant ophthalmologist and retina specialist, VR surgeon. He is a general manager of Amun Eye Center in Jordan. Go ahead, John. So the first presentation, it will be today. It will be, we are going to discuss cases, medical retina cases, dilemma. What can we do? And we will enjoy, inshallah, discussion between all our panelists and speakers. And our first speaker will be Dr. Madaf Rao. Madaf Rao, please.
Okay. Share my screen. Can you see my slides, sir?
Yes, please.
See my slides?
Yes. Yes, please, go ahead.
Good evening, all. Thank you, Dr. Mohammed, for inviting me to be part of this August gathering. It's a fantastic platform to discuss the medical and surgical retina cases, which is happening almost every month. Now, I would like to present a medical retina case. She was a 43-year-old female teacher. She visited to us in the month of February 25th with complaints of blurring of vision in both eyes since 1 week. She had received a second dose of COVID vaccine a week before. And the same evening, she started noticing something wrong in the eye. And incidentally, she was diabetic, hypertensive for 10 years on medications. Her insurance, medical aid was not accepted at our center. In fact, she was visiting the other centers, other hospitals for the past several days. She wasn't improving, so she called up regularly the call centers of Department of Health to inform them that she has problems, which is progressive blurring of vision, and she probably feels that she is going to lose her vision. So the call center directed her again to the higher authorities at Department of Health. Then finally, she was referred to us. When she approached us, her visual acuity was 0.15, improving to, not improving in the right eye, 0.04, improving to 0.08 in the left eye. The intraocular pressures were normal. Slit lamp showed occasional cells, a mild flare in the anterior chamber, and the pigments on the lens in the left eye. We have taken pictures in both the machines. The top images are from the Heidelberg, which is multicolor images, which shows multiple pockets of subretinal fluid in the posterior pole and the macula. You can also see ultra-wide images of the optos, the lower two images, which again shows hyperemic disc, a disc edema with multiple pockets of subretinal fluid at the posterior pole and macula. Now, on our OCT, this is how it was looking. I would run through the video of the right eye. Now you can see a loss of foveal contour with a subretinal fluid. Now, what is important to understand in this is she had hyperreflective dots in the subretinal space. She had a large multiple pockets of subretinal fluid and sort of septae separating them. It was a retinal fold, multiple retinal folds, RPE folds, and the choroidal folds. Now you can see it on our OCT that you cannot probably see the choroid. The choroid is very much thickened. So these are all the features which typically points out to particular condition. By now, most of us would have understood what the condition based on the OCT findings. Now there are based on the OCT findings itself, it's been said that if you see a multiple pockets of subretinal fluid with hyperreflective dots, this goes probably, I mean, it's almost like 95% it correlates with one particular inflammatory condition. We'll go to the next. So this was a fluorescein angiogram, which showed a hyperemic disc with a disc leakage, and the initial choroidal patches of choroidal hypofluorescence becoming hyperfluorescent in the late, and also becoming a pinpoint hyperfluorescent, increasing in size and intensity. The doctor wasn't very particular because of the huge amount of subretinal fluid. You don't see well. So what is the management in such cases? Would you like to stop, Dr. Mohammed, or shall I go ahead?
It's okay. We can stop here and just have an opinion, even though one of the colleagues already sent a message of our attendees and he's participating. Let me hear any opinion from Dr. Ahmed with us here, Dr. Ayman, Dr. Danish, Patricio. So if we are agree, I think most of us will agree, but let us hear. So Danish, what is the highest differential diagnosis?
I actually thought in terms of VKH only.
Yes, okay. Dr. Ayman? If there is something different, I mean, we don't want to repeat. If all agree, well and good. Dr. Ahmed, you are with us?
Definitely. Yeah, I agree totally with VKH, but usually the patient have some other history to be the first presentation, maybe with a questionnaire for the patient. A thorough questionnaire would definitely will add one or more clues as well for a definitive diagnosis of VKH in such condition.
So there was no vitiligos or dermatological, neurological. She just gives a history of she's diabetic, obese, hypertensive, and then she receives the injection COVID vaccine, the second dose, and on the same evening she starts noticing a issue.
Which
okay, can I ask Dr. Iman? Do you think Dr. Iman is there is something related to?
It was Sinopharm.
Okay. Okay. What do you, Dr. Iman? Do you think there is any relation to vaccine? You are mute. Can you unmute yourself, please?
Sorry. Honestly, I've seen myself about 7 or 8 cases of uveitis following vaccination. Unfortunately, I don't have yet the number of patients who can allow me to separate them into specific patterns. But I do have my uveitis following vaccination patients. I agree with the dear professor, and I need some more experience with the vaccine, because vaccination in Egypt is still on the rise, and we are seeing more and more patients and gaining experience in that. I agree with your excellency for the opinion, and for myself, I'm getting to know these patients more and more every day.
Thank you, ma'am. It was such a wonderful comment.
Any other comments from any other colleagues here?
Yes, I think I thought of Harada syndrome first when Dr. Madaf has presented, because I couldn't see a lot of the anterior segment signs to say that this is a Wakianagi Harada. There is no hair change, there is no poliosis, etc. So I think most probably this is a Harada syndrome affecting the posterior segment mainly, rather than VKH. Thank you.
Yeah, the Haradas component of VKH.
Yeah, it's basically.
Yes.
Okay, go ahead, Dr. Danish. What your comment?
Yeah, I was just, because of the other elements not being there. So it is, as the professor said, it's basically Harada's disease, which is again a form. I mean, it's part of the complex of VKH. So it's the Harada's disease form. Yes. So the only issue is, why should, I mean, is there any other, as you know, Dr. Ayman was also trying to point out, there seems to be some relationship of these vaccines with.
I'll come to that, doctor. Yeah.
So you'll be coming to that.
When we see such cases of inflammation, obviously, I mean, with multiple pockets of subretinal fluid, so we would do investigations. So what sort of investigations we have to do?
Yes.
For those, all the medical retina practitioners, we have to do a color images, the autofluorescein, the intravenous fluorescein angiogram, the indocyanine green angiography, the OCT, and the EDOCT. The EDOCT gives us the choroidal thickness and octa if possible. Not necessarily it will give any additional features, but the EDOCT is very important for a prognostication. We would understand how is the choroid behaving in the subsequent follow-ups. And the ultrasound B scan, obviously, I mean, before the OCT, EDOCTs, we used to do ultrasound to show that there is a choroidal thickness. In this case, also the choroid was thickened. It was almost like 2.83 millimeters. And we would do a complete uveitis workup, including the HLA typings. So we sent her back to where she was, the insurance aid was accepted. And she did all these, including the CSF analysis and the MRI brain, just to rule out, you know. And then we started on the same evening, intravenous methylprednisolone, 500 milligrams twice daily for 3 days, followed by oral prednisolone. Whereas on the topical, we started her on a prednisolone acetate 1% eye drops and a Nevanac 0.1% eye drops.
Yeah, was the patient?
And this is a week later. She was presented on 25th of February. This is 4th of March. You can see fluid is almost resolved. There's a thin layer of fluid in the subfovea or the submacular space in the right eye as well as in the left eye. So the vision jumped from the counting fingers 0.04 to 0.4, improving to 0.8 in the right eye, 0.7, 0.8 in the left eye. And then this is how it is seen on a color pictures. How can I go? Yeah. So at the same time, after the first week, we decided we cannot give her a oral prednisolone for a very long time because she's been a diabetic. Obviously, her the glucose level went up suddenly to 300s and shot up to almost 400. She's already obese. We didn't want to create further complications. So we discussed and we decided to put her on immunosuppressive mycophenolate mofetil, 1000 milligrams twice daily. We also told her that she needs a full blood count and a liver function test every 6 to 8 weeks. And though she was at 40s, we informed her she should avoid the pregnancy because it can induce teratogenicity. And this is subsequent result on March, a month later in April, 3rd of April, see a foveal contour maintained and what you can see is probably a thinning. In fact, there is a small thinning of the neurosensor retinas. This is how it is seen. Not a typical sunset glow, appearance of the fundus. We further reduced the oral steroids and kept minimum because of the diabetes, and we continued with the tapering of topical steroids. And this is in May, after a couple of months. Her vision improved to 1 in almost in both eyes with correction. And you can see the OCT.
Okay.
And here I want to say something about VK syndrome. I'm sorry for the typo errors.
Can we ask a few questions, Doctor, before you move to your conclusion? So you treat her, that's you mean your decision that she is a VKH, and treat her accordingly?
She is a part of Haradas, and basically she didn't have any other dermatological or neurological symptoms. She presented only because of a vaccination. We probably correlated this to the vaccination because there was no other positive. Otherwise, the HLA typing was normal.
So what is that? Okay, you can maybe when you are present. Okay.
We went through the literature search, and we saw, this is very recent one, published in July 5th of 2021, reactivation of VKH under control for 6 years, more than 6 years, following anti-COVID vaccination. And there is also VKH seen in other vaccinations, like yellow fever vaccination. This is again a paper published this year, a VKH following influenza vaccination or hepatitis B vaccination. Some of them are from India. In fact, the following influenza vaccination is from India. And there is one paper which article says about the VKH following BCG vaccination and tuberculosis. So why does the VKH syndrome occur? VKH disease results from an autoimmune process, and it is directed against melanocyte-associated antigens, which can be controlled when early and sustained immunosuppressive treatment is introduced. So that's what we do, or the body takes care of these antigens. It seems that anti-SARS-CoV vaccination can behave like a origin of reactivation on long-term controlled disease, or it could even cause a new disease. This was the theory. Yes, doctor.
Thank you very much. Is there any question or any comments, Dr. Ahmed?
Excellent case, Dr. Madhav. It shows us clearly that after the vaccination, and especially when we are in the era of the COVID and COVID vaccination, we are facing new problems, and we need to face it and deal with it. And I agree with you totally. It's a typical Harada or VKH, part of the VKH syndrome. And I had actually more than 6 cases, if I remember exactly, of active uveitis after vaccination. Usually it is, my presentations are usually anterior uveitis, some cells and KPs, and some vitreous cells. Some they have periphlebitis, but without any edema or cystoid macular edema. So it was dealt with just with topical treatment with steroids and anti-nipafinac just to reduce this activity, and it went away. But I agree with you totally. We always need to be vigilant with dealing with such cases.
Can I go ahead, Doctor? I've come across uveitis in my practice as well, but what I have seen more often is retinal vascular occlusions. I've seen at least of 3 to 4 retinal vascular occlusions. Now, why would I relate it to COVID vaccination? These are all developing probably within a week or maximum of 8-9 days. So
yeah, this is very common. I have more than
massive.
I have at least
full-blown picture of a complete vascular occlusion, like a retinal hemorrhages in all the quadrants. a significant macular edema,
Yeah.
you treat them as good as, though you investigate and all, then
Yes.
finally you end up doing an anti-VEGF. They improved, all of them improved, but this is how I've been managing them.
Yes, I agree with you. I have a lot of cases of CRVO and branch retinal vein occlusion, either unilateral or bilateral. But I was talking about uveitis only, without any vascular occlusion, BRVO or central retinal vein occlusion. But central retinal vein occlusion and BRVO is very common. I've seen it a lot.
Can we listen to Dr. Danish? I think he is having some comments.
Vaccination. Yeah.
Dr. Danish,
I was
please.
just saying that the vascular occlusions are sort of very common following the disease process per se. The COVID infection per se is very often related with either venous occlusions and sometimes even combined occlusions. I have, in fact, one of the patients, I made a diagnosis of COVID. The patient, she was a doctor and she'd been working in the COVID ward. And she had a history of fever and everything. And during that time, they said, no, this is not COVID. They said it's dengue. She came to me a month later after this process, and she had a sudden loss of vision. And she had a combined central retinal vein occlusion with a branch retinal artery occlusion. And I said, this looks to me more like COVID. So now it's too late to get the RT-PCR, but get your antibodies done. And she had high antibodies. So the disease process, when the acute disease gets finished in COVID, during the latter part, you can get vascular occlusions. I haven't seen a frank vascular occlusion following the vaccination, but I have one patient of venous stasis retinopathy, which developed within 24 hours after the vaccination. But the important thing here is that the vaccination seems to induce immunity at the level of the RPE and photoreceptor cells. Because I have another patient just seen yesterday who had a retinal pigment epithelial complex inflammation, epitheliitis, RPE epitheliitis. That entire layer got inflamed and the patient had a severe loss of vision. So that would be probably one of the part of that entire spectrum of going up to VKH. It could either become exudative and become VKH, or it could become just inflammation of the RP photoreceptor complex. So we need to put these cases together, and I think we need to bring this out, that this vaccination does cause this problem occasionally.
The case
yeah,
was
it would be great. We can collect some of these patients to present it, whether the branch retinal or central retinal vein occlusion. I think it is worthy of collection, definitely.
The case was reported to pharmacovigilance team of Department of Health, Abu Dhabi. So we have periodically giving them an updated medical report.
Yeah, but I mean as a paper.
Yeah.
Okay, can we? I think Dr. Iman, she wants to say something. Yeah.
Thank you so much for the excellent presentation. May I ask for the panelists' experience? Is one type of COVID vaccine more, in your experience, associated with ocular problems than the other? In my experience, it's the AstraZeneca one. I have people who literally lost their vision following the vaccine. Maybe it's incriminated and maybe it's innocent, but they came to me with kind of PL vision.
We are in India, we are giving AstraZeneca and another one called Covaxin. So we only have these two. The Covaxin is a killed virus vaccine. There are less of these. Maybe there are less of these with the Covaxin, but AstraZeneca, definitely we have had these reactions. Now, Dr. Madhav, what was your case due to?
So it is as good as the killed vaccine, like Covaxin. Here it is Sinopharm.
Okay.
It is the Chinese have got two, Sinopharm and Sinovac. Yeah, these are killed vaccine, killed virus. Yeah.
Okay, I think we can move now to the next talk.
Doctor, do you have a time for a second case, or we'll come back later?
We'll come back later, maybe, because already we have half an hour. Already your case is very nice and excellent, and a lot of discussions. Thank you, Madhav. Maybe we'll have it in the end, inshallah. So we can go. If there is no any comment, we can go to the next talk, Dr. Iman.
Thank you.
Yes. Okay.
Good evening, everybody. It's a pleasure and an honor to be with you all tonight. I'm very grateful for Professor Dr. Mohammed Al-Amri for giving me the opportunity and the kind invitation to be with you. And for tonight, I'll share a case which I named an unfamiliar presentation of a familiar disease. Actually, the diagnosis is very common, at least in Egypt, because the country lies within the geographic distribution of the disease. However, the presentation is a little bit new to the, or a little bit less familiar than its classic presentations for the ophthalmologists. She was a 45-year-old female who suffered from bilateral chronic non-granulomatous anterior uveitis for a total duration of 4 years at the time she was referred to me. She used to get topical steroids, maybe systemic steroids, 1 or 2 short courses, and the uveitis did not settle completely over 4 years. The ophthalmic evaluation, nothing in the posterior segment, a little bit diminution of the vision. Her best corrected visual acuity was 624, in the right eye and 618 due to some cataract, some synechia encroaching on the normal sized pupil. Otherwise, no big problem, no big vision threatening problem in the fundus. She had no significant pain or ciliary injection despite the activity at the time of examination. She had cells +4 and a little bit of flare, maybe more in the right eye than the left. Over 4 years, her several ophthalmic examinations ended with the quote-unquote a very common diagnosis, idiopathic anterior uveitis. She was told this is the kind of uveitis which is a local reaction which your body and your immune system attack the uvea. Systemic evaluation, I had a look on this lady's body. She had significant edema of the whole right upper limb. Her whole right upper limb was much larger in girth than the left upper limb. Actually, when she tried to put on some clothes, the right arm could no longer fit into the sleeve. And her history gave us some very interesting data for this. Because of this right upper limb edema, she underwent a series of surgical operations. In 2010, she developed numbness in the palm of the right hand, the hand of the arm with the edema, and she was diagnosed as carpal tunnel syndrome. And she underwent incision of the flexor retinaculum because she was told that it was the median nerve that was impacted under the flexor retinaculum, and we have to cut this ligament, which is annoying the median nerve. And the upper limb edema as a cause for the compression of the median nerve was overlooked. The following year, she developed pallor of the same hand, which was so severe according to the history she gave, and they told her this is called anatomical snuff box syndrome, and that if you do not get incision of the tendon of the extensor pollicis longus muscle, the muscle that extends the terminal phalanx of the thumb, then the hand will get into gangrene and we will have to amputate it. And this lady was right-handed, so she got scared and she agreed to cut this tendon. And as you see, the terminal phalanx of the thumb is flexed because the muscle that extends it has been severed. And for the second time, the edema itself as a cause for the impaction or the pressure on the radial artery was again overlooked. The following year, the edema increased massively, and she was then respected, the edema was respected and diagnosed as thoracic outlet syndrome, for which she underwent a heroic surgery called pectoralis minor muscle excision. They reflected the pectoralis major, the major muscle of the chest, and they removed the small, you remember from the anatomy, the small muscle underneath it. They thought that this is the muscle that's closing your veins and that you will keep in this suffering for life if you do not just dip inside and remove the muscle. After this surgery, the edema increased even more. And they told her then it was not the pectoralis minor muscle that was closing your venous system, it is the first rib. And we have to excise the first ribs in order to free your venous flow. And this is the letter from her orthopedic surgeon. He said status post pectoralis minor excision, and I'm planning for first rib excision. The lady was scared, but he told her if we do not remove the first rib, then the limb will not move again. And they did remove the first rib, which is a heroic surgery because the first rib is the only complete ring of ribs, though she had a kind of dramatic experience. And after removing the first rib, she was admitted in the hospital and she underwent some electrophysiologic assessment, which said no thoracic outlet syndrome. This is part of her discharge report, saying that you are not a case of thoracic outlet syndrome as a result of the electrophysiologic studies. However, we have to discharge you, we have no diagnosis for you. And then after the pectoralis minor muscle excision and the first rib excision, her right shoulder could no longer move due to iatrogenic periarthritis, inflammation around the shoulder joint, and you need to replace the shoulder in order to gain some mobility in the right upper limb. And the lady was getting prepared, preparing her money and her blood donors for the blood transfusion, just in case she needs it for this big surgery. And at the same time, in the interim period, she had a coma. She lost consciousness and she was admitted in the intensive care unit. In the intensive care, they found brain edema, and they said, still, we are looking for the cause. We do not have a clear cause for this edema. At this particular time was my kind of entry into the scene. This is the time of the referral, and I shall share with you tonight how we try to reach the diagnosis by giving a hint about a short hint about a systemic approach, a systemic kind of thinking, and an ophthalmic kind of thinking. Now, the findings we have is anterior uveitis, upper limb edema, brain edema, all of them quote unquote diagnosed as idiopathic, and clearly a missing diagnosis. There's something missing there which we need to explore. The systemic approach, just in case it's interesting for some of you, is really not rocket science. So just kind of two simple questions: what is the lesion and where is the lesion? What does she have? What's the diagnosis? The name of the lesion is simply venous occlusion, because this lady's edema was very pitting. So this is occlusion of the drainage, venous not lymphatic, because the venous edema is pitting, at least in the beginning. So this lady's edema was venous obstruction somewhere. The second question is, where is the lesion? Where could this obstruction be? The edema of the whole upper limb localizes the obstruction to being at or proximal to the subclavian vein, the big vein under the clavicle that drains the upper limb. Edema of the brain means obstruction at or proximal to the internal jugular vein. And because she had brain edema and upper limb edema, then the lesion was in the superior vena cava, which is the common stem for them. Obstruction of the superior vena cava is known as mediastinal vein syndrome. What is the mediastinum? The mediastinum is the tissues between the heart and the lungs that occupy most of your chest, and it supports the big vessels of the thorax and the neck. So this lady has Behçet's disease presenting by mediastinal vein syndrome. And in this lady, we find a different presentation than the one with oral ulcers and genital ulcers that we wait for or ask for when we meet a patient with uveitis. Behçet's disease causes inflammation of the connective tissue of the mediastinum. The swollen, inflamed tissues compress the superior vena cava, causing a mass-like effect. This is the venogram, the confirmatory venogram I asked when I thought that the obstruction is in the superior vena cava, and it showed extrinsic compression of the superior vena cava for this lady. Now the ophthalmic approach, how does it conduct us to the diagnosis of Behçet's disease? The presence of intense cellular reaction in both eyes and a relatively white and quiet eye, no significant pain and no significant ciliary injection, yet although it is not specific to Behçet's disease, but it raises the suspicion of Behçet's disease. We know that uveitis can occur in white and quiet eyes, like Fuchs uveitis, like GIA, like Behçet's disease, like Postner-Schlossman syndrome, like ulcerative colitis. These are just examples, but it limits the list of differential diagnoses to a few causes. For example, a disease like ankylosing spondylitis comes out with an explosive attack, redness, and photophobia, and so on. But Behçet's disease can come in a white and quiet eye. The message I'd like to say is not the treatment. The treatment is present in any kind of text, whether ophthalmic or internal medicine text. The message is that Behçet's disease, a common cause of uveitis in my country, can present with many presentations. One of them is occlusion of the superior vena cava, and interestingly, this presentation is more common in females than males. I've seen myself about 4 cases, and all of them females. The treatment of Behçet's disease recovered what could be recovered from the patient's manifestations. However, the disability due to the fibrosis following the several surgeries could not be recovered by medical treatment. My take-home messages is when dealing with a case of uveitis, let's remember that the mission of the ophthalmologist is not to get rid of the cells from the anterior chamber. The body is one unit, and uveitis could be part of a systemic disease. Every disease might have several outfits, several dress codes, several presentations. We should not limit our focus to one presentation and just wait for it, because failure to recognize the whole picture and the different presentations of the common diseases in your region of the world, because we know that uveitis is a regional problem. It differs from one part of the world to the other, can lead to serious morbidity, disability, up to death of the patient. Thank you so much. And I thank again Professor Mohammed Al-Ami for inviting me to be with your nice company tonight.
Thank you very much, Dr. Iman, for a very interesting case. I think it's an unusual presentation, maybe, and maybe we can have comments from any of our colleagues here. And also I have Dr. Ashraf Awaja. I think maybe he already, whenever you start giving your presentation, he gave his diagnosis, and it was, he said, Behçet, vein stasis, cava vein, and he's asked a lot of questions that anyway, he gives the, I mean, from the start, the diagnosis. I think he is aware to be with us also here. Okay, if there are any comments, any from our Dr. Ahmed starting, Dr. Ayman, Danish, Madaf.
Thanks a lot, Dr. Iman. Excellent presentation and
so
a very nice case.
Thank you very much. Thank you very much. It's really a pleasure to be with you today.
Any comment, Dr. Ayman?
Dr. Ayman, thank you very much. This is an excellent presentation. But the pity in this case is that in every case, this is what's important. I think this should be the message of your case. In every case of uveitis, we have to investigate it properly. If this patient was investigated properly from the start by doing the HLA-B5, the tuberculin test, can you hear me still?
Yes, yes, we are with yes.
The tuberculin test, the HLA-B5, we do the X-rays, the chest X-rays, we do the lumbosacral, we'll do the other immunological test. This would have probably point out to the diagnosis earlier. When you showed the bilateral dirty uveitis, I said this is most probably Behçet disease.
Yes.
It looked like this is the dirty uveitis that we learned when we were medical students. So doing the proper thing, doing the simple investigations at the beginning, as you said, this is our rule as ophthalmologists. We just don't look at the eye itself.
To get rid of the cells.
We don't clear the cells, as you said. Thank you very much. This is a very interesting case. Thank you, Dr. Iman.
So thank you so much. Most welcome.
Thank you, Dr. Iman. It was very nice and interesting. If you can stop share, please.
Yes, sure.
Dr. Ashraf, if you can open for Dr. Ashraf Awaja, if you want to have any comment. Dr. Ashraf, if you are with us and listening to us, can you please just open the mic for him, John? Dr. Ashraf? Okay.
Yes, hello. Yes.
Yes, أهلا مرحبا دكتور أشرف, كيف الحال?
مرحبا الحمد لله. Thank you
very
for
interesting comments. Very interesting comment. I like your comment very much.
Very interesting, but because we, as uveitis specialists, we like general medicine. You like in detail examination. For example, maybe this coincident. My cousin, my relative, previous week I discovered he has Behçet because he did surgery of vein in the leg. I asked him, why you young age, why you did operation on the leg, varicose? It is strange, your age 20 years. I asked him about he has oral ulcer or genital ulcer. He surprised, say yes. I sent him to this week. I say to medicine doctor. He approved he has Behçet because recurrent vein thrombitis, superficial thrombitis. He did operation, unfortunately. The vein, I discovered he has Behçet.
I think what happened with the same case for Dr. Iman, she present, she is, I think it's exposed to a many surgery, maybe unnecessary, and her problem, it was something different. Anyway, I think the message is very clear, and we can now move to our next speaker, Dr. Danish. We are happy that you are with us. The mic with you.
I'm sorry.
Yeah, go ahead, please.
But you didn't ask me for a case. I haven't made any cases.
Really?
Yeah, because you told me to be panelist.
No, that one in the conference, not here. I think you mix. Anyway, no problems. So
I actually didn't prepare any case.
Okay, no problem. Maybe that's why Madaf. That's why my Madaf, he prepared 2 cases. I think he knows that you are going to.
I will present the case instead of you.
I think Dr. Danish, he mixed.
I'm sorry. I mean, I didn't figure out that you wanted me to present a case over here.
No problem. It's okay.
It is our pleasure to have you with us.
Your presence is very nice and very.
Definitely.
Yeah, sure. So we can move to Dr. Patricio to present his case. Patricio, you are there?
Yeah, I'm coming. I'm here.
So please travel fast.
So Madhav is going to get away with the second case, huh?
Yeah, but if you make your presentation more longer, so we'll not give him a chance.
No,
So play with the time.
I was trying to cut off the speed up. So we're going to talk about a case of diabetic papillopathy. You don't have to squeeze your brain too much because you already know the diagnosis. This is a male that was seen in the clinic with a very poor control diabetes mellitus type 2 for the last 16 years. You can see the numbers of the glycosylated hemoglobin, 11.3%. Patient had a vague history of retinal detachment surgery. I didn't see anything like that. An history also of intravitreal injections in his right eye. The corrected visual acuity was 0.1 in the right and 1 in the left. The slit lamp examination was within normal limits, so was the IOP, and there was no presence of any RAPD, but there was a blurred right eye disc margins. So, as in the previous case, when we see something, we try to see it as a whole, and the patient was sent to neurology, endocrine, and then we did our ophthalmology workup. These are the fundus pictures, and you can see, let me see if I can put the laser pointer. Yeah, you can see that the margins of the right disc are blurred. There are some hemorrhages, flame hemorrhages. The left disc is not blurred, but it's a crowded disc. There is no capping. There is an area of exudates and a cotton wool spot and flame hemorrhage here. These are the color pictures of the disc of the right eye and the fundus autofluorescence. You can see an enlarged area of hypoautofluorescence. And this is the OCT of the right eye. We can see the macular OCT, and we can see that there is, although the central retinal thickness is within normal limits, there is some subretinal fluid coming probably from the disc and extending underneath the central macula. For the left eye, just the typical chronic diabetic macular edema with a center involving diabetic macular edema and thickened retina, especially at the papillomacular bundle. The OCT of the right disc shows subretinal fluid at the roughly 7 hours, and an increased thickness at the superior and inferotemporal part of the disc. And the left disc also had this 2 hours increased thickness, but it's related to the macular edema. It's not because of any disc problem. These are the visual fields where we can see something like a constriction around in both eyes. And this is the fluorescein angiography. Let me see if I can stop this. No, the pointer is killing me. Okay, now the arm eye time is roughly normal. It's around 12 seconds, and then you will see that the filling of the disc is coming now. Very soon after the arterial filling, and there is not too much delay in between the arterial and the arteriovenous phase. So basically, not a big deal. It's roughly speaking, the filling is practically within normal limits. We'll see now the angiography at a late frames of the angiography. And we can see that the right eye has, there is no MVE or MVD. There is a severe non-proliferative diabetic retinopathy with some peripheral ischemia. And there is leakage at the disc at the end frames. For the left eye, there is also an area of capillary closure, maybe some new vessels here. But there is no practically disc leakage in the left eye. So what is diabetic papillopathy? First is a diagnosis of exclusion. We cannot start saying that because the patient is diabetic and comes with edema in one or both eyes is straight away that diabetic papillopathy. You put it aside and then you examine the patient properly. It can be uni or bilateral. With some of them have, I believe there are more cases than the ones we see with very good vision. There could be vision loss, but some of them have very good vision. It affects patients for type 1 and type 2. And in most cases, the course is benign. Some of them can go on to a form of non-arteritic anterior ischemic optic neuropathy. The pathophysiology, well, it's not proven that it is because of diabetic macroangiopathy. It's not related to diabetic control. Most cases do have a long-standing diabetes, but it's not really proven. most likely is due to a prelaminar level irreversible optic nerve ischemia. The incidence in normal population is a rare disease, is 1 in 200,000. In diabetics, the incidence goes higher, up to 3 to even 5% of them. Ophthalmoscopic, as I also said before, usually they're crowded discs with no clear margins. It can affect only some sectors of the disc, as you saw at the disc OCT. That is increased thickness of the retinal nerve fiber layer with or without macular edema. You remember in this one was no center involving macular edema. And there was a serious macular detachment. So not all the serious retinal macular detachments are CSCR. It's difficult to differentiate from anterior non-ischemic optic, anterior non-arteritic ischemic optic neuropathy. But the feeling of at the time of doing the angiography can help you. If there is good feeling and little delay while you're looking at the disc, probably that can give you a clue thinking that this is diabetic papillopathy. Differential diagnosis, if it is bilateral papilledema, non-arteritic ischemic optic neuropathy, arteritic ischemic optic neuropathy, papillitis, MVD, malignant hypertension, pseudopapilledema, and papillophlebitis. Prognosis is usually very good, resolving on its own in between 4 to 10 months after onset. This patient cleared on his own after 3 months. Some can progress to non-ischemic, non-arteritic anterior optic neuropathy with worse prognosis. And some of them can present a moderate neuropathy after resolution with disc pallor and reduction of the retinal nerve fiber layer thickness. Treatment, there is no big numbers. There is no anything like double-blind study done with these patients. Usually observation do fine, and it's been reported that intraocular steroids or intraocular anti-VEGF can accelerate the recovery. In conclusion, again, it's a diagnosis of exclusion, usually presents with minor vision loss, and it can be overlooked. It can be an accidental finding. Associated to macular edema or other diabetic retinopathy findings may evolve to NION with worse prognosis, and it's been reported encouraging results with intravitreal injections of steroids or anti-VEGF. In the end, this is a clinician-based decision, and thank you so much, Dr. Alambri and my dear colleagues, for the invitation and being here with you today. It's my pleasure.
Thank you very much, Dr. Patricio. It's very nice and excellent presentation. Very nice. I will leave the comment for Dr. Ahmed. Okay, Dr. Ayman, he's okay. Dr. Ayman, go ahead.
Thank you, Patricio. You in fact, presented an excellent case, and it's very important because we see this quite frequent in our practice. And it's very important to differentiate between an non-arthritic ischemic optic neuropathy and diabetic papillopathy. I think, as you said, the most important differential diagnosis is the vision. Usually with diabetic papillopathy, the vision is slightly affected in comparison with the ischemic optic neuropathy. This is the most important differential diagnosis. The second, usually in diabetic papillopathy, you will find the hemoglobin A1C is elevated, the blood sugar is not controlled, and as you've shown, there is a lot of diabetic changes in the fundus. So it is a diagnosis of exclusion, and I want to thank you again for presenting this case. It's of a very clinical importance. Thank you.
Dr. Ayman, I want to ask you, because you comment firstly, the vision of this patient, as I saw with Dr. Patricio, it's 0.1. I think it's very
not
poor.
related. It's not related to the vision loss. Is not related to the optic disc lesion. The vision loss was related to the diabetic changes in the macular area, as you can see. It's not related.
But can we ask Dr. Patricio, this is the first time to present for you, or?
No, I've been following this patient for, as I said, more than a year now. He recovered fully. I think that the vision loss in the right eye was a mix, as Dr. Ayman has pointed out. There was a subretinal fluid there, although the thickness was within normal limits. but there was subretinal fluid, and then the visual field, there was no central scotoma. So I don't really think that it was too much related to the papillopathy. And I also really believe that we overlook many times this diabetic papillopathy because it's within all this nightmare of the diabetic retinopathy, and the patient is having a mild loss of vision that we don't pay specific attention, because we are retina guys, specific attention to the optic nerve. But I think that in this case, yes, there is a sort of mixing between the affectation of the papillomacular bundle and the subretinal fluid, what is giving this drop in visual acuity.
I want to ask you a very specific question, Patricio. What is the things that make your mind direct your mind to this diagnosis? I mean, and instead to say this is maybe related to optic neuritis or whatever, not diabetic papillopathy.
As I said, there was no relative afferent pupillary defect, but nevertheless, we sent the patient to neurology. They did a full examination, they did MRI. There was no pathology related to any affectation of the optic nerve sheath or optic neuritis or anything like that. So, as I said, it's diagnosis of exclusion. So you can exclude other causes of disc edema. It's in this case, it was unilateral, but it's more confusing if it is bilateral. So you only reach this diagnosis when you have ruled out all the things that you can think about. I don't know, Lyme disease, demyelinating disease, trauma, anterior ischemic optic neuropathy, anterior non-ischemic optic neuropathy, and the like, hypertension, pseudopapilledema. When you don't find any of these things, then, and the patient, of course, has to be diabetic.
Yeah.
Sure. This is the diabetic.
I suppose if you found a patient who did not have an afferent pupillary defect, relative afferent pupillary defect, and had an altitudinal defect, or did not have an altitudinal defect on the fields, had probably some increase in the blind spot, and the vision loss was mild to moderate. And if you did the OCT, you would actually find the edema on the OCT also. So you would be reasonably sure. And specifically, if you also did an OCT angio to rule out any neovascularization in that area, because otherwise you could mistake a sector of leak for a neovascularization. Then you have a reasonably clear diagnosis in front of you if you put these things together.
Yeah, at the fluorescein angiography, there was no neovascularization. Of course, you have to examine the patient, as I said before. And yes, they usually present with a reduced peripheral visual field, or as you said, arcuate scotomas, altitudinal defects. Yeah, they don't follow a neurological pattern.
I agree totally with Patricio, but I would not consider it as a diagnosis of exclusion. Rather than it would be on top of my list in all patients, diabetic patients. Whenever I've seen some drop of vision which is not related directly to the diabetic retinopathy, and some minor edema in the optic disc, minor or major edema of the optic disc, unilateral or bilateral, I would put this one as the first diagnosis. I would rule out anything else to make sure that my initial diagnosis is the right, is diabetic papillopathy. So if it is bilateral, I would send for MRI just to make sure that it is not papilledema. Relative afferent pupillary defect is crucial. If it is minorly affected, I think it goes with the diabetic papillopathy. My question is for Patricio, because you mentioned that the status of diabetes is not a major effect on the diabetic papillopathy. Usually in my practice and what I thought of, and I learned through the years that better control of the diabetes itself, it can settle the condition of the diabetic papillopathy in a better way. And a systemic treatment with vitamins, especially vitamin B complex, is usually beneficial as well in such cases. Even without any injection, whether intraocular or subtenon. I would go into intravitreal injection or subtenon injection whenever it is there is a combination where there is diabetic macular edema and the papillopathy. So I will treat both, but not essentially just for the diabetic papillopathy.
Yeah, the thing is that we don't have numbers in papers, published papers, saying that all of us think is the real life. I mean, it's a poorly controlled diabetes, it's a patient in a long-standing history of diabetes, hypertension, cholesterol, and all the complications you can think of. And yeah, I agree. And when you have a look at the patient, you say, well, this is diabetic papillopathy for sure. But again, you have to rule out all the major things.
Definitely. Yeah.
Thank you.
Any other comments from other here? Dr. Madaf, you have any comments?
Well, it was a nice presentation, Dr. Patricio, as usual. So for me, I would look at whether it is acute presentation or a chronic presentation. If he has presented as acute presentation with a sudden loss of vision, I would incline more towards non-arteritic anterior ischemic optic neuropathy, especially with a vision of 0.1, which is quite moderate to severe vision loss. On the other hand, diabetic papillopathy is more of a chronic. They won't come with complaints of loss of vision. It's happening over a period of time. So when we come to our clinic, probably we would see and say, oh yeah, he is developing a diabetic maculopathy. The second thing is about the disc at risk. Now I saw both the disc to be a small crowded disc, which you also recognize and you had put it across in the slide. So we all know that the disc at risk, which throws into a non-arteritic anterior ischemic optic neuropathy. The visual field. Now, visual field is very important in diagnosing, if it is an altitudinal, definitely it suggests it's non-arteritic. On the other hand, I mean, a centrocecal scotoma probably would have said a papillopathy. So looking at all these features, looking at even the intravenous fluorescein angiogram, I would go more towards the non-arteritic anterior ischemic optic neuropathy. And even in these cases, some of them do well. Now, when they come back, probably you would see them, the optic nerve to be having a sectoral pareil. In the initial examination, you might see the whole disc to be having a swelling. But when they come back, probably you would recognize either the superior half or the inferior half having a definitive pallor. And the visual field would definitely suggest then.
What we do is actually an artificial differentiation in between, because both of them are anterior ischemic non-arteritic neuropathy.
Yeah, microangiopathies.
Yeah, so it's just the degree of damage that you can recognize and how the patient recovers, what makes you think that maybe this is actually a MEOM and this one is only just a diabetic papillopathy. Yeah.
Thank you, sir.
Thank you very much, Madaf. Dr. Iman, you have any comments? You are mute, Dr. Iman.
No, I agree totally, and it was an excellent presentation, Doctor. I followed it all and took some even notes, but I really cannot find anything to say except to upload.
Thank you very much, Dr. Iman. I think now we need to move to our next speaker, Dr. Ayman Medanat. Dr. Ayman.
Can I share my screen? I think. Can you see my screen?
Not yet, Dr. Ayman. Okay, now it's okay.
Now you can see it, I think. Okay.
Yes.
Good evening. I'm going to present probably more than one case quickly. I hope it will be interesting. Case number one. This is a 9-year-old child. He's hyperopic, wearing glasses since he was 1 year old. His right eye is +8, coming up to 0.4 vision, corrected. Left eye +10, -1.5 astigmatism, coming to 0.1. Referred to us by the pediatric ophthalmologist with abnormal fundus picture. He has been seen by a lot of ophthalmologists. There was a lot of different diagnoses. And I'm going to show you, this is his fundus picture, and this is his peripheral fundus picture. Any clue of the diagnosis?
This time I will ask Dr. Danish Talwar. So if you allow me, Dr. Danish.
Are you looking at the angioma, doctor?
You're absolutely right. When I looked at the fundus, I was looking for any angiomas and hemangiomas. I could not find. There was no
hemangiomas. For it to connect together, I was looking for no
leakage, no hemorrhage, no leakage, no edema, no subretinal fluid at all.
Only tortuosity of the vessels.
Yes.
Okay. What it came to your mind, Dr. Danish?
No, this is in all the quadrants. If it had been in one quadrant, I'd be looking for Weber-Mason syndrome. But arteriovenous malformation. But this is all the quadrants, and I don't think they're connecting to each other.
This is all the quadrants of both eyes, in fact.
Yeah. So it doesn't fit in.
It didn't show anything. Let me just.
Have you checked for hypertension in this child?
He's not. He's systemically, he's quite normal.
Because a severe.
Can you look to the, optic disc?
A pediatric case with hypertension can also have this kind of picture.
Yes, but the patient systemically is quite normal.
Did you check any other
pediatrician?
Any other relative?
Ophthalmologist, and he was checked before the patient was referred to me. He was completely normal. So.
Did you check the relatives?
This is a very important question. Relatives. Yes, there are two brothers. He's the eldest brother. I examined his younger brother. He's 5 years, and he was normal. But this is very important. This is a very important question. Do you have anything in mind?
Just familial vascular tortuosity as such.
Yes, this is the diagnosis. This is a familial retinal tortuosity. This is a very rare disease, in fact, but I want to show it because whenever you see it, you will not forget it. This is the second case I've seen in my life. I've been practicing for the last 39 years. This is the second case I've seen in my life. It's a rare disorder with autosomal dominant inheritance. This is an important issue to examine the siblings. It is characterized by pathognomonic pattern of progressive pronounced tortuosity of the arterioles of the second and third order in the macular and peripapillary area, developing during the childhood or early adulthood. We have to know that this situation might be complicated by intra or pre-retinal hemorrhage, and ophthalmologists should be aware of the condition as a possible cause of retinal hemorrhage. Let me show you something. When you look at the picture, you see that the arteries mainly that are tortuous, not the veins. The veins looks fine, and the arteries mainly look tortuous. This is
Dr. Ayman. There is no microphthalmia because he's very hyperopic.
The problem is he's not microphthalmic at all. The problem is if you look at the vision is affected. The vision is affected because of the amblyopia. This patient has been highly hyperopic since birth, and he started wearing glasses since he was 1 year. And 1 year old child wearing glasses usually is not constant. He used to probably drop them, put them again. So the patient has amblyopia more pronounced in the left eye because the left eye is more affected by the hyperopia. This was the case.
Yeah, because usually in hyperopia, it is very common to see this, not this typical image of tortuosity, but definite tortuosity of the veins and arteries, a crowded disc, and this would cause
crowded vein rather than tortuosity. In the hyperopic patients and high hyperopic childs, when you look at the disc, you'll see that the disc is crowded, and it is. Probably you should differentiate if this patient has.
No, the disc here is not crowded at all. Actually, the disc looks fine because there is the cup is maintained. So this is a point of differentiation that we should always look at. But I mean, usually hyperopes, because we should give a message as well that whenever we are looking for a hyperopic eye, we need to differentiate it from a bit of normal eye. Usually, these eyes have very tortuous vessels. Not exactly the same picture. This is definitely much more, but usually they do.
Professor, do we
Absolutely,
have
Ahmed.
an OCT of this?
I totally agree. The disk is normal. Usually the disk in the hyperobes is more crowded, and sometimes you want to differentiate this from papilledema.
Professor,
So
do
there
we
is a
have
question from Dr. Madaf. If there is what OCT, right?
Yeah. Is there a OCT images?
I did an OCT. In fact, I didn't put it. The OCT is normal.
All right.
Because sometimes in microphthalmia there is a crowded and cystoid macular edema, and this folds. Because I had a lot of patients with microphthalmia and with a more typical.
The OCT was normal. Take it from me.
Yeah. Okay. Great.
We can go to case number 2. In fact, this is a simple case presentation, but I wanted to present this case for one important reason. I want to send a message for my junior colleagues. This is a 37-year-old lady with history of type 1 diabetes and insulin for the last 30 years. She's been diabetic for 30 years, and she's poorly controlled. When my colleague examined her in the center, she looked fine, and just she asked me to come and look. When I looked at the fundus, in fact, I didn't like. I've seen some small microaneurysm. If you can see one here, you can see one here, you can see one here. I didn't like it that much, so I asked for an OCT and OCTA for the patient. When I looked at this OCT, the phase looks fine. The macula is normal. This is the right eye is the same. So I went further and I asked for fluorescein angiography. And this was her fluorescein angiography. Look, and you see the microaneurysm that was not apparent with a fundus view. And when I looked at the periphery, of this patient, it's quite ischemia. The peripheral retina of this patient is quite ischemic. Look at this. This is the right eye. And if you look at the left eye, this is the left eye. Look at the left eye. It's horrendous. It's a lot of ischemia. And this patient definitely, if was left alone, she will go into problems. So what to do? What is next? Do we do laser for this patient? Do we laser her? Or do we just follow her up? What do you think?
This is excellent.
Can we ask Dr. Danish?
This is an Iraqi patient coming to Jordan to visit. She's going back home.
So you will send it back to us, you mean, or was Dr. Anam? Okay, Dr. Danish, can you comment, because I know you are very expert in this field.
Okay, see, basically, even if you go back to the ETDRS study, okay, it says if you study the fluorescein angiographic risk factors for developing of proliferative diabetic retinopathy, eyes which have a 360, all 4 quadrants of ischemia of central of capillary non-perfusion, they have a chance of almost 50 to 60% of going into proliferative diabetic retinopathy within a year. So, as Dr. Ayman said, this patient is at high risk of going into proliferative diabetic retinopathy. Now, unless the ETDRS has worded its conclusions very, very cagily. It says, you should treat it when you need not treat when it is severe NPDR or even early PDR. But if it is high risk PDR, you must not wait. At the same time, if you feel the patient will not follow up, etc., you may consider. So, effectively in today's world, I will not wait. If the patient has so much of capillary non-perfusion, I would do laser for this patient. I would do a PRP, but I would make one modification. This patient doesn't have any neovascularization. I will confine my PRP to the periphery, starting from the ora. I will go beyond the equator till the limit of this area of capillary non-perfusion and save a minimum of 2 disc diameters on each side of the arcade, so that my 30-degree field completely remains unchanged. It will not get affected. You can even, in this particular patient, you can even leave 3 disc diameters. This patient, if you're leaving this patient, if this patient is not going to be coming back soon or doesn't have a regular follow-up, she's safer with that than if you leave her alone.
Thank you very much, Danish. You've said exactly what I'm intending to do. Exactly.
I think
Definitely, this patient is listed for laser tomorrow for two main reasons. Number
Professor?
one, can you hear me?
yeah, we are hearing
Yes.
you. Okay, I think
number one, she is traveling back home, so I will not follow her up soon. Number two, she has definitely a big chance of developing probably neovascularization and vitreous hemorrhage. And I've seen it. I've seen patients, especially with type 1, coming to me with one eye vitreous hemorrhage. When I look at the other eye, the diabetic changes in that eye does not look that aggressive, you know, just some scattered microaneurysms. But as I showed you, the problem is in the periphery. So please, if you look back at this patient, you would send her home. If you are a casual examiner, you see this patient is fine. Come back for re-examination in 6 months. This is really bad. Look carefully at each quadrant. If you find any microaneurysms, any abnormality, go ahead and do a fluorescein angiography. Fluorescein angiography is a very important test. I do it for every diabetic patient with diabetic changes coming first time to me to examine the periphery. The wide field examination of the retina is very important. So I'm going to do definitely laser for this patient. So fluorescein angiography is still an important tool to look for diabetic changes in the retina and should be done for every diabetic patient, even with apparently minimal retinal changes as I've shown you. The retinal periphery should always be examined with the wide field fluorescein angiography, and ischemia in the retinal periphery of diabetic patient can be a cause of sudden vitreous loss or vitreous hemorrhage, due to subtle neovascularization. So please do always examine the periphery in the diabetic patients and manage properly. Added to that those patients might develop macular edema because of the VEGF that's released by the ischemic retina in the periphery. So some of the patient, even if they don't have a lot of diabetic changes, they probably might have some sort of macular edema later in their course due to this peripheral ischemia.
I think, thank you, Dr. Ayman. This one, an excellent case. Actually, I asked Dr. Danish to comment about this one because we have one session special for that before, I think on, if you remember, Dr. Danish, on March. And we talk about that. And I think Dr. Ayman with us that time, I think. Yeah, we talk about this one and the management and when we to use an anti-VEGF, it's also on the rule of anti-VEGF in these cases. Okay, I think Dr. Madafi is having a comment, please.
Yes, Professor, it was a fantastic case and a presentation. Yes, I do agree with the role of fluorescein angiography and with Dr. Dinesh Talwar making a comment of ETDRS, which says probably, I mean, it holds good even for a ischemic CRVOs. If you have more than 20 disc diameter of capillary non-perfusion or the capillary dropouts, you would probably go in for a laser. But my only question is, in this era, would you consider or switch with protocol S in mind and the other, in mind, whether you would switch to anti-VEGF? And also we have a panoramic study which talks about treating severe NPDRs with anti-VEGF and going back 2 steps. So would you like to, especially a patient coming from Emirates, I mean, would you like to do a laser? And they are very, very finicky about having a laser and losing a visual field. So would you consider anti-VEGF in this era?
Danish, please.
Thank you, Madam. This is a very important question. I thought about it. This patient does not have any sign of neovascularization or proliferative diabetic disease. So anti-VEGF, if there was any sign of neovascularization, definitely, even if it was subtle, I would never hesitate to give, in addition to the laser, an anti-VEGF. I start by anti-VEGF, then a week later, I do my laser treatment. But there wasn't, as you've seen in the OCTA and the fluorescein angiography, there was no leakage at all in the fluorescein, only this ischemic areas that I think would definitely be treated probably with a light laser And as my dear friend Dr. Danish said, I'm not going to give her extensive laser. Definitely, this would be a light laser, only to the periphery, up to the limit of the ischemic area, and I will ask her to be followed closely. Definitely, I'm not considering anti-VEGF at this stage, but later
Dr.
on,
Danish,
at any sign
can
of
we have Dr.
neovascularization.
Okay, Dr. Danish, if you can, yeah, please go ahead.
Yeah. So, Dr. Madhav, to answer your question, basically you're talking about the role of anti-VEGFs for regression of diabetic retinopathy. So the fact is that yes, you could consider that, but keep in mind that is basically for regression of the leakage process. It does not cause a regression of the capillary non-perfusion. In fact, there's a study which showed that even if the regression occurs after the anti-VEGF agents, and that did occur in many cases, the capillary non-perfusion continued to persist. So you have a time bomb there which is going to persist, and the moment you stop the anti-VEGF agents, you stand at a risk of that particular area now starting the process of VEGF production again. There is only one caveat here, and that's the area that needs a little investigation, that if you have been giving the anti-VEGFs long enough, have the capillary non-perfusion areas been converted from hypoxic to anoxic areas, which means they are now dead, in which case they no longer cause any VEGF release. See, we know that. I tell this to my residents all the time. We have these areas of cells which are crying for help. Shoot them, they are dead, they don't cry for help, the disease goes away. So the point is, are these capillary non-perfusion areas going to become anoxic? We don't know. So I would not risk, till we know that, till we have a way to find out, differentiate anoxic from a hypoxic area, is better to destroy the hypoxic areas, the capillary non-perfusion areas, because it's not the neovascularization we are worried about. As you said, we are not talking about regression of the neovascularization. We are talking about regression of the retinopathy. And the regression of the retinopathy will occur in terms of leakage. It will occur in terms of microaneurysms. It will occur in terms of beading, but it won't occur in terms of capillary non-perfusion.
Dr. Talwar, I would agree with, what this is the theory we are talking about, but there is a clinical trial study of the efficacy and safety of intravitreal aflibercept for the improvement of moderate to severe non-proliferative diabetic retinopathy, which is called Panorama.
Exactly.
It's a the phase 3 clinical trial, which shows an improvement and a significant 2-stage improvement in the severity of a diabetic retinopathy scale. Yeah. So they actually have done the chances of
what happens is
the chances. I do understand what you said, doctor. You said about
the 2-stage improvement is in the clinical stage, but not in the capillary non-perfusion.
But the chances of
Can I say something?
And they showed that the regression occurs. The 2-stage regression occurs, but the capillary non-perfusion continued to persist on fluorescein angiography. So clinically it improves, fluorescein angiographically it doesn't.
So can I have a quick comment? First, excellent case, Dr. Ayman, because you tackled a very important topic, because sometimes people are looking just for the central area and missing the periphery. And I agree with you, even with the central field, this is a dull photo. So it gives to me an idea that it could be an ischemic. There is some areas of capillary non-perfusion. Definitely fluorescein angiography will show it in a better way, but clinical examination is crucial to examine the periphery of the retina, and this is great. I agree with Dr. Danish Talwar for doing a PRP for the whole periphery, because this is a patient who's traveling. I would not say from Emirates, from wherever, she will not come back to you, and she can be missed, because whenever she goes to anyone and they examine only the central part, okay, no, you don't need, why? He told you you need the laser, there is nothing. But if you document it with the fluorescein angiography, as you did, and you did the laser and the proper treatment, I think the problem is already solved. I agree definitely with my friend Dr. Rao for the protocol S and the panorama study. We have seen regression of the diabetic retinopathy severity scale. And in such cases, if this patient is following up with me, I have both options, whether to give the injection or to do the laser, but provided that the patient is regularly following up with me. He's not traveling, I will not be missing his follow-up visits. This is crucial, or else I will be, as Dr. Dinesh just mentioned, on a time bomb that can explode at any time. So at that time, I would go directly to the PRP, although most probably in such cases, I will do PRP, and I will definitely preserve the central area and go as peripheral as possible.
Thank you, Ahmed, for conclusion. I think you have put all the points.
Dr. Amri, just one point.
Yes, Dr. Ahmed.
In 2000, I did a small study at King Hussein Medical Center. Unfortunately, I didn't publish, but I don't know if Dr. Amri, I lectured about that more than once in Jordan and outside, showing that Avastin clearly decrease the diabetic changes if you give in non-proliferative cases, and not proliferate in non-proliferative cases. But in this case, it's different. The diabetic changes is not a lot. There's a little bit of microaneurysms only. So giving anti-VEGF in this case will not definitely treat the ischemic area. If you want to treat the ischemic area, the only thing is to give laser, mild laser, as my dear friend Dr. Dinesh said. So I would only give laser, but I will keep the anti-VEGF in mind to be used at any further stage down the road if the patient develop any signs of neovascularization or any signs of proliferative disease or macular edema. And until she developed this, I wouldn't use the anti-VEGF in this case.
Dr. Patricio, if you have any comments before we conclude, please.
No, I strongly agree. These changes in the severity of diabetic retinopathy is just a cosmetic change. It doesn't change the ischemic area. It doesn't change the visual field loss at the periphery. And you have to be very careful with the injections if the patient misses the appointments, because the neovascularization will come back even more wild than before the injections. So it's a double-edged problem.
Can I move to my third case?
Okay, you have also still third case, Dr. Ayman? Because Dr. Madhav, okay, if it is very fast.
I hope so. It is. It's an interesting case also. This is a 53-year-old male patient presented to our center with blurring of vision in his right eye, which persists after uneventful phacosurgery done somewhere else. The patient denied any systemic illnesses. When we examined his right eye, his vision was hand movement. There was a few scattered KBs, plus 3 cells in the anterior chamber, no synechiae at all. IOL was in place, 14 millimeter mercury pressure in both eyes, no fundus view, flat retina with some vitreous shadowing. The left eye was 0.8, few cells in the anterior chamber, no synechiae, superior temporal retinal hemorrhages with vascular sheathing. This was the picture, the right eye, this was a dilated patient. I dilated the patient. This was in the surgery room, and this was the left eye. You see the hemorrhages and you see the sheathing of the vessels. We did investigate mainly for Behçet disease, sarcoidosis, TB, syphilis, lymphoma. All these investigations were done and they were negative except for slight anemia and neutropenia. We decided to do PPV and take a vitreous sample for testing. I took the patient to the theater and I did the vitrectomy. I took ample vitreous sample for testing. And while I was doing the vitrectomy, and when the fundus view was clearing, I could see this pizza-like fundus picture as you see with me. So we did investigate this patient for acquired immune deficiency syndrome. and he was HIV positive. The CD4 T cells were 90. Normally, it should not be less than 200. And he was diagnosed with CMV retinitis, more advanced in the right eye. I treated this patient with ganciclovir, IV weekly for 4 weeks, and then kept on oral ganciclovir. This was the vision in the right eye. This was the fundus picture, improved vision to 0.4 in 4 weeks. And this was the left eye. Few weeks later, the patient developed retinal detachment. If you see here, there was inferior retinal detachment. So I took this patient to the theater again, and I repaired his detachment. I'm not going to talk a lot about surgery. This is not a surgical symposium. And this was the result. I did ample laser treatment for all of the retina, and I put silicone oil, and patient was corrected to 0.4 again. And we started the treatment, as I said, and I removed the silicone oil 3 months later, and this was the fundus picture. This is the right eye. As you see, his lesion has improved dramatically, and this was the end result. The right eye 0.7 and the left eye was back to 1. So AIDS patients with CMV retinitis have a high risk of retinal detachment. The success rate of the treatment is less than 60 to 80%. Multiple breaks, which are usually difficult to find, seeking breaks within the necrotic retina. Posterior location usually of the breaks. Usually the breaks are posterior located. The PRP should extend beyond the borders of the breaks, especially with active CMV retinitis, because of the possible extension of the retinitis to normal retina with formation of new breaks. The buccal are not necessary in every case, but intraoperative precautions like double gloves, etc., is necessary. One more thing is that this patient, if you treat those patients, don't leave them. You have to follow them up, because you might expect recurrences. The recurrence of the disease has happened twice. I treated this patient, I think 8 or 9 months ago, and he came back to me 2 weeks ago with recurrence of his uveitis. So don't just stop following up these patients, because they might have recurrence of their disease. Thank you very much.
You
Thank
keep
you very
them,
much,
Dr.
Dr.
Ayman, on systemic antiviral for a long time. You do not stop the antiviral.
No. I did not stop. I gave him, the IV for 1 month, but he's on ganciclovir for oral for quite some time. For the first time, he was on this treatment for around a year. And the treatment was not available in Jordan, the oral tablets. He used to bring them from Egypt.
Okay.
Nice case, Professor Ayman Madhan. So I just wanted to know, has he received the intravitreal ganciclovir, or was it only intravenous followed by what?
Thank you for raising this. This is definitely one aspect of the treatment. You can use this. Yes, you can give intravitreal. I didn't give him any intravitreal, in fact, because I cleared all the vitreous during the vitrectomy, and he improved on the systemic medication only. So there was
he needs an intravitreal as either a ganciclovir or a foscarnet.
Yes. The problem is that the patient was not aware of his problem. He did the cataract surgery, and he did not improve, and he thought that it was related to his surgery. His surgery was done perfectly somewhere else. When he came to me, and I looked at his left eye, and when I examined his right eye, this is where I, in fact, started to ask myself some questions. I thought of the lymphoma, just to be clear, because this looked to me as a normal patient, but when I took history, he was a car dealer, so he used to go to Germany a lot. He used to travel a lot outside of Jordan. But that's probably where he got his age, outside Jordan.
What
Yeah, but
Thank you.
the problem of missing the diagnosis essentially during before the cataract surgery. So
Correct,
examination before the cataract surgery is very important
Absolutely.
to check the retina and to check the periphery of the retina, because we have a lot of cases. You have seen inferior detachment, uveitis, a lot of disease that you need to inform the patient before proceeding for cataract surgery. I know it is done outside of your center, but I mean it is crucial for proper examination before any surgery.
Absolutely.
I think, Dr. Ahmed, also we are doing for all patient HIV. So I think if that's done, it will also solve the problem from the start. You get to know. For us, we cannot go into the theater unless we get the result of HIV. This is another thing. So
I worked, I worked in
government.
after I finished in Edinburgh and Glasgow, I went to Ireland. I was in the Mater Misericordiae Hospital. This was in the early 90s, 91, 92, doing my fellowship. And at that time, the AIDS was so common. And we used to do one clinic for AIDS patient, and I was responsible for this clinic in the last Friday of each month. I used to do this, and I used to see a lot of these patients, and we do operate on some of them for retinal detachment, because patients who develop cytomegalovirus retinitis are prone to detachments. The incidence of retinal detachment in those patients is very high, in fact. And it's not an easy case to deal with, because the holes are usually small. Sometimes you cannot recognize the hole among the necrotic retina, and you have to be very careful, and you have to extend, as I said, your laser treatment, your PRP, to every necrotic part of the retina. And if you can, in this case, in fact, I've done a PRP to all patients, to the whole of the retina outside the arcade.
Thank you, Dr. Ayman. If there is any comments from any other colleagues here, Madhav, you want to give your presentation, or we can keep to the next time? Up to you.
I can present, sir.
Okay, go ahead.
You allow me to present.
Yes.
Okay. Can you see my slides?
Yes.
Thank you, Dr. Alabri, again, allowing me to present the case.
Our pleasure.
Thank you. His 13-year-old boy presented to the clinic on 13th of March with a complaints of sudden drop in vision in the right eye for the last 2 weeks. Prior to our visit, he had visited many ophthalmologists, and they said he has got a significant retinal issue in the right eye. His general health was good. His visual acuity was counting fingers at a half meter in the right eye, not improving further. Left eye was normal. The pressures were normal. Slit lamp examination was essentially normal. Again, the fundus examination showed a macular star. This is how it was looking on a closer look at the macula. This is the multicolor image from the spectralis. And you can see a OCT showing a huge subretinal fluid and hard exudates deposits. We did the retinal fluorescein angiography, which shows dilated tortuous mid-peripheral vessels with the leading on to, these are feeder vessels leading on to angiomas in the superior and superiotemporal quadrant in the right eye, with a lot of vascular sheathing in the inferior retinal vessels, and some amount of capillary non-perfusions. ICGA demonstrated clearly the angiomas, leaking angiomas. In the left eye, there was solitary angioma along the inferotemporal vessel in the mid-periphery around the equator. So this is the OCTA image of the right eye. So by this, I'm sure the Dr. Madnath also showed a similar case, but it was a familial retinal dilation, tortuosity. Whereas here, this is a straightforward diagnosis of retinal angioma or a hemangioma. So you do workup with intravenous fluorescein angiography, ICGAs, and then we decided to do a laser photocoagulation. We used the indirect laser ophthalmoscope to the peripheral retina and to treat the peripheral retina and also treat the peripheral ischemic retinal areas. And for the macular edema, we decided to do an intravitreal injection of anti-VEGF. In this case, we chose ranibizumab. Further, what is more important in such cases is to evaluate for their systemic association. We put him onto our internist. Since he was in a bracket of 14, we put him onto our internist rather than to a pediatrician. And we suggested to go in for all necessary imaging studies. And we also wanted to examine his, he was the lone son. So we examined his father. And incidentally, his father had a similar issue. He was not diagnosed at the right time and he had become blind in the right eye. In fact, he was very happy to meet us and go through the treatment. In the course of, he kept saying how he missed the right diagnosis during his childhood days. His vision started improving to 0.5 in the subsequent visit, and the left eye was clearly normal. He had still had a cystoid macular edema and a few angiomas. Without wasting time, I will show how he improved. This was the OCT, which kept improving. We probably did the second intravitreal anti-VEGF. And 3 months later, his vision improved to 1 with the minimal correction. So what we need to understand in such cases is a rare vascular tumor. It's sporadic or a part of von Hippel-Lindau disease. Retinal angioma was first described in 1864 in patients who died because of central nervous system angiomas. Early diagnosis and treatment of retinal angiomas with an appropriate systemic workup for associated systemic disease can prevent visual loss and the morbidity and mortality. The clinical features include sudden visual loss, like in our patient, swelling of the optic disc, peripapillary and macular exudate. These exudates can be seen as, the angiomas can be seen as orange lesions in the periphery. In our case, despite knowing the fact that this condition can lead to a devastating anatomical and visual results, like his father's ocular condition, in our case, immediate diagnosis, management with focal and sectoral laser, anti-VEGF resulted in a good visual result, and anatomically with the regression of angioma and macular edema. Now, the angiomas could be bilateral. It could be multiple retinal hemangioblastomas are associated with von Hippel-Lindau syndrome, and the patient should be evaluated for this condition using a brain and renal imaging as well as the genetic testing. Solitary retinal hemangioblastomas may also be associated with the VHL syndromes. This is how the classification of von Hippel-Lindau syndrome. If he has got a family history positive, then we need one of these features to call it as VHL. Or if it is negative, we need 2 or more retinal hemangioblastomas or 2 or more brain hemangioblastomas, or it could be single retinal or brain hemangioblastomas with any viscera involved. So which are the, we should look for renal cysts, renal cell carcinomas, pheochromocytomas, pancreatic cyst, islet cell tumors, or epididymal cyst adenomas and endolymphatic sac tumors. So this is how they need to be investigated. We need to do imaging studies to look at all these possible tumors and how frequently we should investigate. There's a beautiful table given, suggested by Carol Sheets, and it says we need to at least examine them annually for physical examination, retinal examination, fluorescein angiography, brain MRI or a CT scan, abdominal MRI or CT scan every 3 years, and a 24-hour urine VMA at least to be done once in a year. So the management and course, it's not just for the hemangioblastomas. We should look for the systemic and ocular evaluation more than the ocular evaluation. And it is given by a Cambridge protocol. If they are a small tumors less than 3 millimeter size, laser photocoagulation or the photodynamic therapy can be used. If it is medium-sized hemangiomas, you can do a PDT or a cryotherapy to the peripheral lesions. And if it is more than 6 millimeter, either you can use a PDT, plaque radiotherapy, or internal resection by a pars plana vitrectomy route can be employed. We need to be very careful doing a vitrectomy in such cases because we need to ligate them. Otherwise, it can cause or do a endocautery to prevent intraocular hemorrhages. These are my references. Thank you.
Thank you very much, Dr. Madab, for this an excellent presentation, an excellent case. One question: how frequent we can see this type of tumor?
I think I've come across at least around 3-4 cases during my practice.
I mean the percentage available. How?
They are rare. They're not,
incidence?
Yeah, incidence it's not that common. It's uncommon.
Okay. Is there any question or comment about the case presentation from any of colleagues
One
here?
comment I would like to make, especially in the ones which are a little bigger, just make sure that you keep on hitting these with laser till they completely die off. They will often not go away in one sitting. So I will normally do a scatter laser all around them first, so that it should not, because otherwise you're always scared of it causing exudation around it. So if you've lasered around it, and then after that you finish the laser, then the scatter laser, and then you go ahead to the direct laser over the tumor. If you can identify the artery very clearly, then you first try to crimp the artery, and then you go ahead and do the substance. And you may need to do it more than once. It's not, so the best way is to keep on hitting it till it completely regresses, and don't give it a chance to come back. Otherwise it keeps coming back. I have heard people saying, it didn't go away. It didn't go away. It doesn't go away because you let it come back. So don't let it come back. Laser today, see after a week. If it's still there, hit again till you get a complete resolution of that tumor. That's the important thing.
Probably I did not mention in the case presentation. In this particular case, I did the sectoral. I chose to do a laser on the feeder vessels initially.
Yes.
And when it started becoming thin, probably then I considered doing a focal laser onto the angiomas, and more than one sessions. Probably we have done already 3 to 4 sessions. So we are following the right. Yeah. So we are following the right protocol, and it has resulted in a gliosis now.
Yes, so, but you see, this is the problem. Supposing you don't do it on time, and the gliosis occurs first, then later on the laser doesn't work. So if you do it before the gliosis occurs, if you're doing it every week till it finishes off, gliosis will occur later on. By that time, the tumor is gone. So that's the important thing.
Okay.
So
Any
very
other
important
comment?
Thanks a lot, Dr. Dinesh.
One question.
Yes, Dr. Batish.
For Madab, you review the literature. For PDT, you use it in a special way, or just the normal full PDT, or half fluence, half time? I don't know.
I think the normal way. You can use it as a normal way.
Okay. Yeah. Thank you. Very interesting. Nice case.
Any other comment, Dr. Ayman? Dr.
I think
Ahmed?
you do it for 83 seconds exposure.
Okay.
Oh, it's a very nice case.
All cases are excellent, presented by all dear colleagues. Yes.
I was, in fact, thinking about the same thing as Patricio. As long as you are treating the macular area, don't you think that a half fluence VDT would be probably less damaging to the retina in this case?
In this particular case, there was no posterior pole angiomas or the macular angiomas. It was only in the, as I showed in the angiogram, it was peripheral.
Sorry, I didn't follow because the internet connection was not clear. I lost you in the middle of the presentation.
Yeah, probably I could have.
There wasn't any, because I've seen leakage and edema in the macular area.
So it was a macular steal phenomena. You could see a lot of exudations in the macula with a typical macular star appearance. I chose to.
No angiomas in that area.
No, there was no angiomas in the macula or in the posterior pole. So it's all in the periphery. So we chose to do it either with a laser or a cryo. I had an option of laser or a cryo. I decided to go in with the laser and the multiple sessions of laser. For a macular edema, we injected anti-VEGF and we got an excellent response. And he's
I think
improved
with
until 2020.
With such case, it's cryo. I would not really go with it because it's mid-peripheral. It is not peripheral lesion and it is not solitary angioma. So I think laser would be the go for such case, the go-to for such case.
Is there any comment? I think we have come to the end of this session. It was an excellent, and I am happy that we have this eminent speaker, very nice and excellent presentation as usual from each of you. Even though we are go behind the time, but everyone is enjoying, I mean, discussions and having this information and getting experience and have information from expert people like you here. I'd like to thank you, all of you, and thanks all our attendees and participants. And thanks for our sponsor company, Alimera, for sponsoring this event. And I'd like to just to invite all of you, they are listening to us, to our conference that is going to be held on September from 23-25, MEOM, the third MEOM conference. And we are having a very eminent speaker, and it will be this time the theme of the conference, case-based discussions. So it will be almost similar to this one. And I would like to invite you all to enjoy. And it's a free registration. Everyone can attend these sessions and this conference. There is a CME accreditation, more than 100 international speakers. We are having about 50 of speakers from local and regional area. Thank you very much for this excellent webinar meetings, and we hope to see you inshallah soon. On 27th of August, we have a glaucoma sessions. Till that time, thank you and goodbye.
Thank you.
Thank you so much.
Thank you very much.
Thank you.
Thanks.
Thank you.
Goodbye.
Thank you, Dr.
Thank you.
Thank you.